Hello, Dr. Hamid. You're always there also in my classes. Okay. Try to participate as much as possible. Try to uh, put your best internet connection possible. And this class will be exactly for 45 minutes. And now the time is starting. Yes. So it's 10:30 now. Let's start. Hello, everyone. Welcome to Pediatrics by Dr. Anand. This is the Usmle / Mrcpch / Plab series part 4. In this session, I'll be asking you questions. Try to participate as much as possible. Question number 1. The question number 1 is a 4-week-old boy, a 4-week-old boy came with history of 2 days of poor feeding. A 4-week-old boy came with history of 2 days of poor feeding. Okay, this is the pediatric cardiology section today. So try to put your brains over there. The boy was pale on examination. Okay, there were poor peripheral perfusion, poor peripheral perfusion. Okay, try to use your brains as much as possible. Poor peripheral perfusion. I'll repeat again, a 4-week-old boy. A 4-week-old boy with history of 2 days history of poor feed, and he was pale, he was having poor peripheral perfusion. So the question now is, which is the most important diagnostic method, for this child to diagnose him for coarctation of aorta? Which is the most important diagnostic method if I have to diagnose this child as coarctation of aorta? The options are: number 1, so I hope you have got the question. 4-week-old boy with history of 2 days history of poor feed. He was pale, he was having poor peripheral perfusion, and the question now is, which is the most important diagnostic method for diagnosis of coarctation of aorta, COA? So the options are: number 1, palpation of the femoral pulse. What do you think? Is this the diagnostic method of choice for coarctation of aorta? Yes or no? Put your answers in the comment section. Palpation of femoral pulse. Palpation of femoral pulse, is this the diagnostic method of choice for what do you call coarctation of aorta? Next we have four limb blood pressure. Four-limb blood pressure, do you think is that the diagnostic method for coarctation of aorta? Okay, if I tell you chest x-ray, anyone? So is chest x-ray the best diagnostic method of choice for coarctation of aorta? And if I tell you, okay, auscultation, just auscultate the heart, sir, just auscultate the heart. So what do you think? Among these 4 options, which is the most diagnostic method of choice for coarctation of aorta? What do you think? Anyone? Random guesses? So options are: either we do a chest x-ray, 4-limb blood pressure, auscultate the chest, or palpation of the femoral pulses. So okay, let's go one by one. Okay, chest x-ray. Chest x-ray, we all know that the chest x-ray, what do you see on chest x-ray? Do you see rib notching? Yes or no? So please remember, on chest x-ray, do you see rib notching? But chest x-ray having rib notching will be a chronic finding, It will not be the diagnostic method of choice. I'll repeat again. Chest x-ray, most importantly, remember, see, all these points are somewhere connected to coarctation of aorta actually. But what do you call, I'm asking regarding the diagnostic method of choice. So chest x-ray is not the option, because I agree, chest x-ray you see rib notching, but that's a chronic finding. And remember, option number B, C, and A, they all are important in diagnosing of coarctation of aorta, but they are non-specific. Please remember, please use your brains. 4-limb blood pressure is important, chest x-ray is important, auscultation is also important, but the book says that, Nelson says that it is basically a non-specific finding. So that is why palpation of the femoral pulses is the diagnostic method of the choice for the coarctation of aorta. I hope you have got the question. Question number 2. A 5-year-old girl, a 5-year-old girl on examination, a 5-year-old girl on examination, she was having a 2 by 6 soft systolic murmur. A 5-year-old girl on examination, she was having a soft 2 by 6 soft systolic murmur at the left sternal border. Please use your brains. Cardiology is like maths. Once you understand everything. A 5-year-old girl on examination, she was having a 2 by 6 soft systolic murmur on the left sternal border. The murmur was loudest. The murmur was loudest on the lying position, but on the sitting position, it was not audible. Okay, the murmur, it was loudest on the lying position, but on sitting position, it was not audible. There is no history of exercise intolerance. There is no history of exercise intolerance. There is no history of shortness of breath. There is no history of exercise intolerance. There is no history of shortness of breath. There is no history of hospitalization. This is the patient's first episode is coming to you. There is no history of hospitalization. Please use your mind. Every single point is connected. There is no history of hospitalization. It is the first time ever the patient has come to you. And last but not the least, there is no history of family history. There is no family history. Okay, this is the full question. A 5-year-old girl came to you. You just found a small 2 by 6 soft systolic murmur at the left sternal border, which was loudest when she was lying, but when she was sitting, it was not audible. There is no history of shortness of breath, or palpitations. There is no history of exercise intolerance, no family history, no history of previous hospitalization. It is her first ever episode. The options are now the question. What is the question? The question is, which is the best investigation? If I tell you some investigations, which is the best investigation you would like to do in this case? What is the best you would do? Options are, number 1, you will get a ECG, chest X-ray, and echo. That is the first option. You will do a chest X-ray, ECG, and echo of this patient, number 1. Number 2, you'll be doing something known as exercise stress test. Exercise stress test. You'll be doing something known as exercise stress test for this patient. That is the second option. Exercise stress test. Option number 3, we have refer the patient to a cardiologist. Refer the patient to a cardio. And last but not the least, you reassure the child, the family, that it is a innocent murmur and discharge the patient. So what do you think? Anyone? What do you think? A, B, C, D. What's your favorite number? Anyone? Annapurna, what do you think? Any random guesses? What do you want to do in this patient? The options are, you want to do a ECG, chest X-ray, and echo. Options are, you want to do a exercise, a stress test. You want to refer the patient to a cardio, or you want to just reassure the patient that nothing is there. It's okay. It's an innocent murmur. So point number 1. So very good. So we have Manasa. Manasa has got the best answer. The best answer for this question is just reassure the patient, and as it is an innocent murmur. Now, why, sir? Why this is? I don't understand why this question. Why just reassurance is the best answer? Please remember, ECG, chest X-ray, and echo. It was useful. It is a good useful investigation, but it is a useful investigation if you're suspecting a congenital heart disease. Okay, this is the first time the patient has come to you. There is no previous history of hospitalization, no history of recurrent upper respiratory, lower respiratory tract infection. It is the first ever the patient come to you. That is why in general, ECG, chest X-ray, and echo you will not do, because it is useful if you are suspecting some congenital heart disease. Okay, congenital heart disease. Now next is exercise stress test. Exercise stress test, again, it is done for screening for coronary artery disease. Exercise stress test It is done for the screening of coronary artery disease. For if you put the patient on some treatment, you put the patient on a treadmill, and is usually done for coronary artery disease. Again, for this question, exercise stress test, it's not important. So best answer, as it is a Stills murmur. The answer is the murmur which this child is having at the left sternal border is nothing but an innocent murmur, nothing but a stills murmur. Okay, it's an innocent murmur or nothing but a stills murmur. For this patient, nothing to be done. Just chill out. Everything will be fine. Okay, next question number 3 we have. What is true about TGA? A very simple MBBS question. You have to tell me what is true or false about TGA. TGA. Okay. Question number one. So TGA is a duct dependent congenital heart disease. Is it true or false? TGA, it is a duct dependent. It is a duct dependent congenital heart disease. What do you think? Is it a true statement or a false statement? Very good. So we all know that, right? In TGA, we have this small, our heart is there. We have the right atrium, we have the right ventricle, we have the left atrium, we have the left ventricle, and here in transposition of great arteries, this is the aorta and this is the pulmonary artery. So this, in this section, definitely a ductus is required for the persistence of circulation for the survival of the baby. So the answer is true. Yes, it is a duct dependent congenital heart disease. Number one. Number two, okay, it is, if I say it is more common in boys are more common than the girls. So what do you think? Is it true or false? Is it more common in boys? True or false? Anyone, any random guesses? It is more common in boys than girls. So what do you think? Is it false or true? Any idea? It is more common in boys as compared to girls. So Nelson says it is true. It is actually more common in boys as compared to the girls. Okay, remember that. And question number 3, the point number 3, it is the most common cyanotic congenital heart disease at day of life 1. Is it true or false? Anyone? The most common cyanotic congenital heart disease at day of life 1. Yes. So it is true. So in this condition, actually all are true. There's nothing false in this. The book says it is more common in boys as compared to the girls. Next question is a very interesting question. We have a 7-month-old child. We have a 7-month-old child having stridor since birth. Listen carefully. We have a 7-month-old child having stridor since birth. You know, right? Stridor is a low pitch inspiratory sound, basically, So 7-month-old child having stridor since birth. Okay, number 1. Number 2, he has a very faltering growth. His growth is not proper. Okay, 7-month-old child. Now listen carefully. Maybe you get an answer. Maybe I'll give you a chocolate. So he's having faltering growth, number 1. He's also having occasional episodes of vomiting plus choking. Okay, I'll repeat again. 7-month-old child having stridor since birth, his growth is not good. He has occasional episodes of vomiting and choking. On examination, the cry of the child was normal. Please remember, every word is important. The cry of the child was normal, but there was inspiratory stridor. Okay, I hope you're able to understand. 7-month-old child having stridor since birth, and growth is not proper. He's vomiting here and there, choking, but the cry was normal, and there was inspiratory cry. There was inspiratory stridor. His weight was 10th centile. 10th. His weight was just 10th centile. Okay, 10th centile. When before, like previously, his weight was 50th, centile, but it has fallen down to the 10th centile, and he is also having a grade 3 systolic murmur. He's also having a grade 3 systolic murmur. Okay. Now, I don't know how will you answer. I hope you will not suicide after hearing this question. You have to, and this is a cardiology session, remember that. So again, 7-month-old child with stridor since birth, having faltering growth, occasional episodes of vomiting and choking. On examination, he had normal cry. Inspiratory stridor was there actually, and the weight has gone so badly down, and he is having grade 3 systolic murmur. Okay, everything you have got it. So the options. Now, what is your diagnosis? Your diagnosis is number 1. Is this a case of gastroesophageal reflux disease? Let's just stick to this option first. What do you think? Yes or no? Do you think he is a case of gastroesophageal reflux disease? Any idea? Any random guesses? So Annapurna is right, Anurag is right. It is not a case of gastroesophageal reflux disease. For every question, I'll be telling you answer rationally also why it is not gastroesophageal reflux disease. See, in gastroesophageal reflux disease, the predominant symptom should be vomiting. But in my child, the predominant symptom is the stridor since birth. Okay, the predominant symptom in my child, it is stridor since birth. But in predominant, what do you call it, the symptom for GERD, it is vomiting, number one. And of course, the cardiac feature in GERD, you don't see cardiac features in GERD. Yes or no? You don't see cardiac features in GERD. So this is not a GERD point. Okay, these questions are really interesting. Try to allow your brains to enter this complicated information, and if you can filter out this, you will crack it. Next option, laryngomalacia. If I say this is a case of laryngomalacia, Monica, what do you think? Is this a case of laryngomalacia? Yes or no? And if no, why? And if yes, then why? Why it is not a case of laryngomalacia? Any idea? Any random guesses? So laryngomalacia, it is not, it is a negative, it is not a case of laryngomalacia, because even though the child is having stridor since birth, even though the child is having stridor since birth, but usually, this child who, let's see, the most commonest cause of stridor in general in babies is nothing but laryngomalacia. We all know that, right? But usually laryngomalacia, the most common cause of stridor in children is laryngomalacia, number one. But why this case is not laryngomalacia? This baby is a 7-month-old. Laryngomalacia, if it was there since birth, usually it resolves spontaneously. Yes or no? Very good, Madhura. So it resolves spontaneously. If it really was laryngomalacia, it would have responded, it would have resolved spontaneously, and this baby is still having stridor. And one more thing about laryngomalacia baby, usually they are thriving well. Laryngomalacia babies, usually they are thriving well, but this baby, he was not thriving well. He was not thriving well. So good. So GRD is not the answer. Laryngomalacia is not the answer. Let's see other two options. If I tell you this might be a case of croup, what do you think? This might be a case of croup. Do you think this can be a case of croup? A 7-month-old, stridor since birth, faltering growth, and all that. Why it can't be croup? Croup? Any idea? Any random guesses? So yes, it cannot be croup. That's very true. So in the croup, basically you see acute stridor. Again, the whole drama is that in the croup you will see acute stridor. Chronic stridor you don't see in croup, right? Chronic stridor you don't see in croup. Murmur you don't see in a croup, right? So yeah, and last option, yeah, and Rohan is also very right. Thumb sign, stipple sign, all the signs of the life, they are not there. Okay, very good. Last option, aortic vascular ring. So the answer for this question was, this child is suffering from aortic vascular ring. Okay, the child was suffering from aortic vascular ring. So that is the best answer for this question. Next question, what is true? What is true about atrial septal defect? Very simple question. What is true about atrial septal defect? We have right atrium, we have right ventricle, we have left atrium, we have left ventricle. What is true about atrial septal defect? Number one, it is a right to left shunt. It is true or false? Anyone? And why? It is a right to left shunt. Is it true or false? Why it is false? Why it is not true? Anyone? Annapurna, what do you think? Why it is not? Anyone? Yes. So very good. So atrial septal defect is usually a left to right shunt. Number one, it is a left to right shunt, because left side usually have the higher pressure system and higher musculature, thicker musculature. These left to, it is always a left to right shunt. Okay, so this is a false statement. Point number one. Okay, point number two, the most common type of atrial septal defect is ostium primum. Is it true or false? The most common type of the atrial in AS, the most commonest type of ASD is ostium primum type of ASD. Is it true or false? Anyone? Let me see any. So Himanshu has the right answer. Again, it is a false. It is a false statement. Please remember, the most commonest type of atrial septal defect is ostium secundum. Ostium secundum is the most commonest type of atrial septal defect, not the ostium primum. That is a very important question, very basic question. Recently they have asked also. And one more, if I ask you, the pulmonary The pulmonary is to systemic. The pulmonary is to systemic flow ratio. The pulmonary is to systemic flow ratio of more than 2 is to 1 is an indication of surgical closure. Yes or no? True or false? Anyone? True or false? The pulmonary is to systemic flow ratio of more than 2 is to 1. We should put a surgical closure to this. This is a bloody true statement. It is. Pulmonary is to systemic flow ratio of more than 2 is to 1 is an indication for surgical closure of atrial, of the, what you call, atrial septal defect. That you should know. Okay, that's a very true statement. Next question. What is true? What is true regarding tetralogy of Fallet? You might have heard this term. We had a class also. Let's see if you can remember. What is true regarding tetralogy of Fallet? What is true regarding tetralogy of Fallet? Option number 1, atrial septal defect is the component. Anyone? The question is atrial septal defect is the component. Anyone? So the answer is no. Atrial septal defect is not the component of the, what you called, of the tetralogy of Fallet. Okay, very good. Okay, most patients of TOF, most patient of tetralogy of Fallet have a left to right shunt. True or false? Most patients of tetralogy of Fallet have a left to right shunt. You sure it is left to right shunt? Do you see left to right shunt in tetralogy of Fallet? Do you see a left to right shunt in tetralogy of Fallet? There is pulmonary right ventricular outflow tract obstruction. There is right ventricle hypertrophy, and there is a ventricular septal defect and overriding of aorta. And I'm saying most patients of tetralogy of Fallet have a, okay, right and left. Yeah, so they have a, so anyone, so it's a totally false statement. How can it anyone say it's a true statement, right? In the, there is a right ventricular outflow tract obstruction and VSD is there. Normally VSD is a left to right shunt, but in tetralogy of Fallet it is a right to left, right? Normally ventricular septal defect is a left to right shunt, but in tetralogy of Fallet it is right to left because of the right ventricular outflow tract obstruction. Yes or no? Pink TOF, if I talk about, if you would have said pink TOF, I would have agreed. The pink TOF is left to right. Why pink TOF is left to right? Because in pink TOF there is a mild obstruction. There is a mild obstruction across the, VSD. So pink TOF, remember, could be a left to right, but in tetralogy of Fallet in general it is right to left. Right to left, it is important that you should know. Okay, very good. Now next question is a very easy question. Let's see if you can answer. It's a very easy question. 14-year-old patient came with complaints of 4 months history of recurrent palpitations. 14-year-old, last two questions left, then the class is over. 14-year-old with a 4 months history of recurrent palpitations. 14-year-old with recurrent palpitations. Okay, number 1. Number 2, these palpitations basically they occur in school. When she goes to school, she get those palpitations. A 14-year-old girl, she has a 4-month history of palpitations, which basically occurs in the school. Okay, lasts for few hours, occurs in the school, lasts for few hours. And how does it respond? It resolves spontaneously. It resolves spontaneously. Okay, it's a very interesting question. Let's see if you can answer. 14-year-old girl, 4 months, from 4 months she's having palpitations, which are actually more in the school, and last for few hours and basically resolve spontaneously. Okay, during this also she's having dizziness and sweating. Very good. Dr. Manasa is trying to answer. She is having dizziness also and sweating also at the same time. Okay, so the highlighters are she is having palpitation, she is having dizziness, she is having sweating. Okay, 3 things this 14-year-old girl is having. Now still the question is not over. The question is again, so she went to a doctor. Okay, she went to a doctor actually, and she told doctor that her exams are there. Her exams are there next week. Like the way Rohan Manwar gets scared when exams comes, like that, her exams are there next week. Okay, her exams are there next week. The doctor checked the BP. The BP was normal. Okay, doctor checked the ECG. ECG, the doctor said will do a 48-hour Holter monitoring. Doctor said will do a 48-hour Holter monitoring. Okay, that also done, it was normal. So now what is your diagnosis? So everyone has already jumping with an answer. So Annie and Priya are telling, okay, if I say, okay, let me put, okay, the options, let me put the options. You have to tell me why this option is not there. Option is supraventricular tachycardia. Do you think it is a case of supraventricular tachycardia? If in a case supraventricular tachycardia, usually patients have palpitations, sweating, dizziness. Why it is not a case of supraventricular tachycardia? It could be, with the palpitation, dizziness and sweating. Why do you think it is not? What is not connecting with SVT? Anyone? What is not? What is the ECG finding you see in SVT? Anyone? So Annie, very good. So as you know that palpitation, sweating and dizziness, they all are the features of supraventricular tachycardia, but but the patient's 48-hour ECG is normal. Normally ECG finding should be there. What is the ECG finding in supraventricular tachycardia? So absent PR interval, absent PR interval and narrow QT complex. The patient should have these ECG finding. If it is a case of supraventricular tachycardia, patient should have absent PR interval and narrow QT complex. But this my patient is having normal ECG, right? That is important. Okay, very good, Dr. Asif. One more thing, if I next option, if I say this is a case of pheochromocytoma, anyone, do you think it's a case of pheochromocytoma? Why it is not a case of pheochromocytoma? What happens in Rohan? What do you think in pheochromocytoma? Very good, very good. So we have Nidhi and we have Priyash. They are telling very nice answer. So anyone, if I'll give you a chocolate, Annapurna. Pheochromocytoma is a tumor of what? Anyone? Which gland? It's a tumor of dash gland. Pheochromocytoma. Can anyone tell me? Asif is telling very right. It's a tumor of adrenal gland. It's a tumor of spelling is wrong. Adrenal gland. And usually it causes what? It causes excessive release of catecholamines. It causes excessive release of catecholamines. Can anyone name me catecholamines? Annapurna, what are the various catecholamines? Can you tell me one or two here and there? Anyone? What are the various? So we have epinephrine, we have norepinephrine, we have a dopamine. All these are catecholamines. So pheochromocytoma is a tumor of the adrenal gland where there is increased catecholamines, increased epinephrine, norepinephrine, and dopa, and that causes very high BP and then headache, and you do a 24-hour urinary catecholamine levels. So, but in my patient, in my case, her BP was normal, very good, and that is why the best answer for this condition will be situational anxiety. She's having situational anxiety. Situational anxiety is the best answer we can think for this baby, for this question. Okay, now we'll ask two questions left, then the session is over. Okay, it's a very nice question. A 12-year-old girl. Okay, so someone is asking me the treatment, the Galaxy Tab A. So please remember, normally reassurance, number one, reassurance, and number two, basically you see the aggravating factors, stressful events, anxiety, so stressful events, all those aggravating factors you should try to relieve. Reassurance is important. Psychotherapy is also important. And remember, psychotherapy, reassurance, and this situational anxiety is a diagnosis of exclusion. You should exclude you should rule out everything and then come for situational anxiety. You should rule out supraventricular tachycardia, pheochromocytomas, and all that. So reassurance, psychotherapy, and aggravating factors try to relieve. Okay, next question. So a 12-year-old, a diagnosed case of ventricular septal defect. Okay, I'll repeat again. There's a 12-year-old who is a diagnosed case of VSD. Okay, thank you. You got the answer. So a 12-year-old with a diagnosed case of VSD came with 7 days history of fever, malaise. Annapurna, are you there or you slept? Night sweats. Okay, very good. So Again, I'll repeat, 12-year-old. So Annapurna is there, very good. So a 12-year-old girl, a case of ventricular septal defect. She's a diagnosed case of VSD actually, and she's coming to you with a 7 days history of fever, malaise, and night sweats. Fever, malaise, and night sweats. Her fever was around 39 degrees Celsius, and she's having a grade 3 pansystolic murmur. She's having a grade 3 pansystolic murmur, and she's also having some kind of lesions on the arms and the legs. So very good, people are jumping with an answer. So everyone is already answering, very good. So I'll just finish the question. So a 12-year-old girl, a case of VSD, came with complaints of some fever, malaise, night sweats. On examination, she had a very high grade fever, and she has some erythematous maculopapular lesions which are non-blanching over the arms and the legs. So everyone is telling the right answer. That the answer for this question, of course, it would be a case of infective endocarditis. Infective endocarditis will be a best option for this case, but that is not the question. The question is, which is the most important, investigation for this case, which is the most important investigation for this case. Options are ASO titer, yes or no. Do you want to get ASO titer in this case, yes or no? What do you think? So ASO titer, of course, sir, ASO titer will tell us regarding the rheumatic heart disease. It will not tell us regarding the infective endocarditis, right? Next option, do you want to get a, yeah, so X-ray, chest X-ray, anyone? And the last option, we have this blood culture. So blood culture, of course, it will be the best answer for this picture. It's a case of, the child is having a congenital heart disease. Now it's landing up into, infective endocarditis. And yeah, that will be the best answer. Okay, last question. So a child having continuous machinery murmur, a child having continuous machinery murmur, which is heard all over the precordium, which is heard all over the precordium. Continuous machinery murmur heard all over the precordium, and femoral pulses are easily palpable. Easily palpable. So the best answer is easily palpable dorsalis pedis artery, easily palpable femoral pulses, and a pansystolic continuous machinery murmur. So what do you think? So even my dog also knows this answer. His name is Oscar. So patent ductus arteriosus. Patent ductus arteriosus will be the best answer for this case. Patent ductus arteriosus. It is a continuous machinery murmur, easily palpable dorsalis pedis artery, increased chances of URTI, LRTI, like a ductal steel phenomenon, hyperdynamic precordium, bounding pulses, and all those things. Okay, last question. A 2-year-old child. Let's see if you can answer this. Okay, the arteries are easily palpable because of the ductal steel phenomenon. Ductal steel phenomenon. That's another 15 minutes question. Just in general, you should know there is something known as ductal steel phenomenon. I'll send you the audio on WhatsApp. And because of that, you have bounding peripheral pulses and easily palpable dorsalis pedis artery. Next question. A 2-year-old child fully immunized. A 2-year-old child, every word is important. A 2-year-old child fully immunized referred to you with suspected measles. A 2-year-old child, he was fully immunized. He came to you with he was referred to you because you are a senior. Annapurna is the senior physician in town. So it's a suspected case of measles. Okay. On examination, you saw a morbilliform rash. What is morbilliform rash? Anyone? What is morbilliform rash? Any random guesses? What do you think? What is morbilliform rash? Anyone? A 2-year-old child, fully immunized, suspected case of measles, came to you, and on examination, you could able to elicit morbilliform rash. Anyone? What is morbilliform rash? And Rohan, what do you think? So morbilliform rash means anyone measles-like, measles-like rash. Measles-like, same maculopapular, like something like a viral or something like a measles kind of a rash, like a measles kind of a rash. Okay, so now the child was having 40.1 degrees Celsius of fever. His respiratory rate was 26. Okay, he was alert, but very irritable. He was little alert but very irritable. Okay, now question is a very interesting question. Let's see if you can answer. So a 2-year-old child, fully immunized, suspected measles, had some rashes, very high grade fever, but the child was very irritable. The child was also having cervical lymphadenopathy. The child was also having conjunctivitis. The child was having some lesions over the palm and soles. Yeah, and the child's CRT was less than 2 seconds. Okay, 2 seconds. Okay, this were the findings in the child: cervical lymphadenopathy, conjunctivitis, and having some desquamation over the palm and soles, and CRT less than 2 seconds. Still, I will not tell you the diagnosis. The question is, what is the first line management? The question is, what is the first line management for this child? What do you want to do? The options are: number one, you want to give vitamin A. The options are: you want to give steroids. The options are: you want to do a lumbar puncture, LP. And the options are: you want to give a high dose aspirin plus IVIG. High dose aspirin plus intravenous immunoglobulin. So anyone? So yes, this case is nothing but a case of Kawasaki. Very good. This is nothing but a case of Kawasaki. Remember, see why it is not measles, because the child is fully immunized. The first pointer only which told the child is fully immunized. It is a case of Kawasaki disease, and this is the highlighter for these questions are: the child was fully immunized. A child who is fully immunized should raise a suspicion of an alternate diagnosis other than measles. And they told everything. About that rash. You know the mnemonic, right? In the measles. So we have same thing. There is a, so yeah, and the child is very irritable. Fever of few days, the child is very irritable. Yes, you should think of, kind of Kawasaki disease. And he is having a rash. He is having edema also. There's a eyes conjunctivitis also, and there's a lesion in the palm and soles also. So everything is connected to the Kawasaki. Can anyone tell me how does the conjunctivitis of measles is different from the conjunctivitis of Kawasaki? Rohan, what do you think? The conjunctivitis of measles is differentiated from the conjunctivitis of Kawasaki. Anyone? Yeah. So measles, see, 3C. Okay, measles has 3C. We have cough, we have coryza, and we have conjunctivitis. But the conjunctivitis in measles is purulent. There'll be sticky discharge, purulent conjunctivitis, whereas Kawasaki will have non-purulent conjunctivitis. Measles will have measles will have purulent conjunctivitis, and Kawasaki will have non-purulent conjunctivitis. So these were the important questions for the Mrcpch and for the Plab and for everything. Thank you so much for the participation. If you're a part of our WhatsApp group, then well enough. If not, then my number is 9999897081 for the free pediatrics WhatsApp group. Thank you, Rohan. Thank you, Arvind. Thank you, Annapurna. Any doubt you have, come on WhatsApp. We will chat and we will discuss the answers. Thank you, Dr. K. Thank you, Annie. How come you are late, Rohan? Always you are late in my classes. Always. I will block you next time. You come next time. Let me see if I'll let you enter in my classes, Rohan. Okay, thank you, OnePlus. Thank you. Okay, late in answering. Fine. Okay.